attending today's Public Health Communications Collaborative webinar. I'm John Auerbach from Trust for America's Health. Today's webinar is being recorded, and that recording and the slides from today's presentations will be available on the Public Health Communications Collaborative website later this week. Today, we're thrilled to have Dr. Lauren Smith, Chief Health Equity and Strategy Officer for the CDC Foundation, Dr. Ayne Amjad, the Commissioner and State Health Officer for West Virginia, and Dr. Lisa Costello, Assistant Professor of Pediatrics at West Virginia University School of Medicine. They will each be sharing important and useful information. But before we get started, we want to give them a sense of who's participating today and what your most pressing communications challenges are. This will help us answer your questions later. So, in the WebEx platform, we would like you to answer these two questions, and we'd like you to answer them one right after the other. They will help us, again, to understand what term best describes where you work and what is your most pressing communications challenge. So let's take a few seconds now. Please complete those survey questions, and again, one right after the other. We won't do one and then wait and then interpret it and then another. We're going to do them both at the same time. Okay, well, I see from the first bar, if it is complete, that the largest group is from local health departments, and the second largest is from state health departments. And we're delighted about that because the primary audience for the Public Health Communications Collaborative is those who are in the field in public health. So that's great. And in terms of the results from the second poll, we see that the number one question is on vaccine confidence. I think that's the question on everybody's mind now, particularly in light of the J&J pause. Now, at the Public Health Communication Collaborative, our mission is to help coordinate and amplify public health messaging on COVID-19. And so we're really excited to kick off today with Brian Castrucci, who is the President and Chief Executive Officer of the Beaumont Foundation. Dr. Castrucci is here to tell us some very interesting polling that has just been done. Literally, this is breaking news that shows that it gives us some insight into vaccine confidence, particularly in light of the Johnson & Johnson pause. So, Dr. Castrucci, eager to see what you have to say.
It helps to unmute. I'm doing a messaging talk and I didn't unmute. That's kind of ironic. So I'm really happy to be sharing these results with you all today. Every public health person, including myself, spent a couple of days last week talking about how this J&J pause could have an impact on vaccine confidence. And I mean, ultimately, this is where polling is so important because we were able to quickly call our partner, Frank Luntz, and say, okay, let's get something into the field and let's see what really happened. And so what we found, next slide, is that the pause did not harm vaccine confidence as much as we had expected. It definitely has an impact on J&J, but most folks were fine with still doing Pfizer and Moderna. This is, I think, an important point. As more people are vaccinated, the divide between party is narrowing. But also remember, the more people that we vaccinate, the quicker we're getting to the immovable no group. And the immovable no group does exist. There are just people who will not get this vaccine no matter what you do. It's a race to herd immunity and to when we get to the immovable no. So don't get discouraged if you're seeing increased concern and even more aggressive concern as we proceed, because you may be getting more to those immovable no's, and that's a natural occurrence as we roll out the vaccine. Definitely the vaccine education efforts are going to show results, but there are some trends that we're going to continue to look at. Rural areas and women among 18 to 39, and even generally 18 to 29-year-olds are showing more concern than their older counterparts. And I think I heard a data point that we have the older US population at 80% or so. Now we're changing into a different time in this vaccine rollout, and it's going to need to be issues of access, and we're going to have a different messaging campaign, because the perception is it's not as life and death with the younger group, and so people want to get it at their doctor's office. We're going to have to reduce a lot of the access barriers. Listen, gang, I'm a type 2 diabetic. I navigated 8 websites to get my vaccine. If I was young, I'm still young. If I was younger and I was totally healthy, I'm not doing that, right? I'm just, unless you can make this super easy for me, and that's not spending hours to get an appointment and then at a max vac site that's hours away with a long line. I think we'll lose young people that way, so we have to figure out how to reach them. Next slide. So here are the good data points. Are you more or less likely to get vaccinated than you were a month ago? People are more likely. We have 36% trending in the wrong direction, but generally 40% of the US population said we're more likely to get vaccinated. Next slide. So I think this is really encouraging. We asked this question. You could pick one of these 3 responses. So asking about the J&J vaccine, is it the pause? Is it a good example of the rigorous safety monitoring? There was that option. It's a good example of why we have to wait and be a little more cautious. And then it doesn't matter to me. So there was a proportion, about 29%, said that this is a good example of why COVID-19 vaccines are possibly unsafe. But generally, that it didn't matter to folks, or 53% said this is a good example of the safety monitoring working. So I think that's a strong message to keep pushing. These things happen when you roll them out into large populations. We stopped it with 6 people because we're prioritizing the safety of the American public. And that's it's for all those folks who said they shouldn't have done it. My argument would be that would have actually been a hit to our transparency. So I think this was a really good, transparent, thoughtful decision on the part of the FDA and the CDC. Next slide. 61% said this is an isolated situation, the vaccines are safe. You had 39% say it may be the first of many serious side effects. Now, the challenge here is the 39%. So it's not a huge number. It's a third, but if we continue to have more of these, that's the number to really watch for. And so right now, we need to be working on our messaging about future pauses or blips. If you're a Marvel fan, we'll just call this the blip. These are the things we have to be thoughtful about. Get the messaging ready now. Next slide. So here are some of the basic messages that worked really well in our polling. The safety message was strong. It's not a lot of people, and just keep that. It's a small number. Keep that number front and center. Have that 10 people versus that 6.8, so people are seeing that, hearing it. These are extremely rare. We're actually trying to think of and work on a different word than rare. I don't know that rare actually adequately communicates just how infinitesimal this is. I wouldn't say that it is rare to get hit by lightning. It's almost doesn't happen. So how do we use maybe a different word than rare? And again, using, that we also had the birth control example, smoking. These are things that can help people put blood clots into context. So do you take birth control? Your risk's actually higher. So just helping with some of those ways, the lightning example in that third one. I think we all understand being struck by lightning and probably don't know anybody who has. And so it's something to hold on to. It's the same way we're trying to contextualize 550,000 American deaths with something like that's 3,000 747s, because we can wrap our brain around what a 747 is. We really can't wrap our brain around 500,000 people. Next slide. So we've been doing some polling and some focus groups, and all of this is available. This happened to be swing voters. This was last night. It was fascinating. What Americans want is really depoliticization of everything that is going on. And so you can check that out at the website I will share momentarily. Next slide. There's another resource that we're coming out with. The number one thing that people want to hear from, number one person that people want to hear from are their own doctors. Every group, every age group, doctors. They want to hear from their own doctors. And so Mike Frazier was very kind and gave us an opportunity to present to the state health officials a couple weeks ago. And one of them said, hey, could you give me something to send to my doctor? Like send to the doctors in the state so that they can use it. And we have this toolkit coming out. It will also be posted on this website, which is the next slide. There you go. If you take off the J&J, you get to our general changing the COVID conversation. That's where all of our messaging lives. If you all are having challenges within your states, if there are messaging questions or problems, send them to me, please. We will have an 18 to 39-year-old focus group sometime next week, and we will have a Black and Brown American focus group later next week as well. We can actually have people watch these focus groups kind of behind the glass wall, if you will. We don't have a lot of seats, but if people are really interested, please let me know, and we'll try to test messages or ask questions that you all have. I think you're muted, John.
Thank you. Thanks very much, Brian. Just great research, is so timely, and the Beaumont Foundation is clearly doing really important polling. So thank you for sharing that with us at the Public Health Communications Collaborative. And also, again, folks who want the slides themselves will be able to get them at the Beaumont Foundation site that you've listed here, I believe. And yeah, we will have those available at the Public Health Communication Collaborative as well. I did note that you said one of those populations that needs special attention is the rural population, so that makes it even more important to hear what our panelists have to say. Brian, before we let you go, I also wanted to note that you've been doing a lot of media work lately on a range of different topics, and one of those topics has been the question around vaccine passports. And in those interviews, as in your other interviews on other topics, I know you've talked a lot about a topic that's of interest to our viewers, which is getting the politics out of COVID-19 vaccine conversations. And that's not always easy to do, particularly when the media asks a challenging question, or or just the fact that we live in a very politicized environment. So I thought it might be helpful to play a segment of an interview that you did with National Public Radio, Steve's Inskeep, where you handled it very well, and I thought people could hear that. It's kind of a lesson in how to pivot when given that kind of question. So it's only a minute segment, but please play it.
Can I ask a cynical question and get your best answer? It would be easy for me to say it does not matter what the Biden administration calls this vaccine requirement. Tucker Carlson on Fox News will call it what he wants, and it'll be the least flattering term, and that's what people are going to believe and remember in a certain part of the population.
That's why we have to get politics
out of this debate. Anytime you have a political debate, there's a winner and a loser. If we don't get Americans vaccinated, we all lose. This needs to be a conversation had by state and local health officials and other medical professionals. Let's not even introduce it into politics so that we don't politicize yet another very important tool in the public health tool chest. We don't need vaccine passports to become mask wearing 2.0. We need to make sure that people have the facts that they need and the freedom to make the choice. And they want to hear from doctors. They want to hear from clergy. They want to hear from their spouses, not politicians. We have to start having conversations throughout this country across the dinner table.
Brian, just a masterful job. You really redirected the potential politically charged question to focus on the real goal, which was vaccinating enough Americans. And so can you tell us a little bit more? You've been doing so many of these interviews. Any insights or observations about what the experience has been like for you with those interviews and how you approach avoiding being drawn into being politicized by the media?
I think I've been taught and continue to hold to the fact that the interviewer in and of themselves aren't necessarily important to what we're trying to do. So they can ask whatever question they want. That's their right. And you can provide whatever answer you want. That's your right. So it's a real just trying to be message disciplined. And it's even, it's jazzed up for someone working at a private foundation that says, we're not, and we are not partisan. We're not even bipartisan. We're not partisan. And so we want to make sure that we're keeping the messages on point and not getting drugged down into, partisan debates. I was doing an interview this morning and the reporter kept saying, there are no Republicans who are, out in front of the vaccine saying it's a good thing. They're making it like mask wearing. And, again, it was just to pivot and say, I've not seen that. I've seen people wanting to talk about it. I think everyone is for the vaccine. They're just saying it in different ways. Some people aren't as forward about it, but let's give them opportunities to do so we can get America to vaccinate, get America vaccinated. So, know your message points before you walk in and know what your overarching message objective is. And for us at the Beaumont, it's every community, every color, every class, every citizen takes this vaccine.
Brian, so helpful. Thank you for the information about the polling, and thank you for that insight about conducting interviews. And I'm sure you'll be back on future Communication Collaborative webinars. And again, folks, check out both the Beaumont Foundation's website and the Public Health Communications Collaborative website for information related to Brian's presentation. Thanks so much, Brian. Now it's my pleasure to introduce the moderator of our panel, Dr. Lauren Smith. Dr. Smith is the Chief Health Equity and Strategy Officer at the CDC Foundation, and she drives strategic efforts at the foundation to embed health equity across the foundation, including, of course, in the COVID-19 response activities. Dr. Smith was previously the medical director and interim public health commissioner for the Massachusetts Department of Public Health and the CEO of FSG, a social impact consulting firm. And she'll be moderating the conversation with Drs. Amjad and Costello. So Dr. Smith, over to you.
Thank you so much, John. I appreciate it. And I want to say thank you to the Communications Collaborative for hosting this very timely and highly relevant conversation on COVID messaging in rural communities, because we just heard just how important and critical it is to do that well. Right now, as of yesterday, we had 211 million doses of vaccine administered across the country with 85 million people fully vaccinated. So those are very good numbers to know and to be able to say. However, and unfortunately there is a however, we know that all of that is not being equally experienced across the country, so that there are inequities by geography, with rural communities which have a higher rate of chronic illness and other factors that put them at increased risk for COVID, also having to face healthcare systems that have been disinvested in and facing additional challenges in terms of closures of rural hospitals, et cetera. So it really is an important issue to be confronting, and we're so lucky to have with us two just leaders from West Virginia to share with us how they have approached this and in fact really been in the vanguard. As we're about to pivot to hearing from our panelists, I just want to remind the attendees that you can put questions into the chat addressed to all panelists, and people will be keeping track of those so that when we get to the question and answer period, we'll be able to respond to those as many of those as we possibly can. Well, as you know, West Virginia has been a leader in COVID-19 communication and vaccination, and Dr. Amjad became the commissioner of the health department in July of last year. Talk about a really tricky time to assume such an important new role. So we'll hear about that. And as she's led this tireless effort to combat COVID-19 in West Virginia, with an emphasis on clear, consistent, and scientifically sound and evidence-based communication. We're also going to hear from Dr. Costello, who's a part of the team at the West Virginia University that's leading research on the most effective public health messaging that works, along with the Joint Information Center, which is part of the West Virginia Joint Interagency Task Force on COVID vaccines. So today they're going to provide their insights and what they've learned from their experiences. First, we're going to have Dr. Amjad, who's the Commissioner of Health for West Virginia. Thank you so much, Dr. Amjad, for being with us.
Thanks, Dr. Smith. I do want to thank everyone for inviting us here today, and I know Dr. Costello is going to do a great job about explaining how they've been doing a lot of research on messaging. So I was going to just go through some slides about our background on how we address the rural population in West Virginia, our Joint Interagency Task Force, and basically how we addressed messaging out to the rural population in West Virginia, because we had a good deal of success coming out at the gate, and a lot of people have asked how we were able to do that. If you can advance to the next slide, please. So before the vaccines did come out into the United States, even West Virginia, we got our first shipment probably mid-December. We had a group meeting task force, of course, led by our governor, Jim Justice. And we knew that our main goals were to protect the most vulnerable, reduce hospitalizations, reduce deaths, and of course, protect our acute hospitals, our acute infrastructure. So leading those in mind, and even across the country, we knew that long-term care facilities, of course, were getting the most brunt end of the force of COVID-19 infections, as well as our elderly population. You know, our 80-year-olds and above, 70-year-olds and above, they were suffering the most morbidity and mortality. So leading out that efforts, and of course that was across the country, that was a population that we wanted to get the vaccines, you know, first. So we knew that shots in arms really fast meant saving lives. So that was our main goal, addressing the vaccine rollout in West Virginia. West Virginia is a rural state. If you haven't had a chance to visit it yet, it is something to go to. A lot of people do pass by, you know, coming from anywhere from New York down to Florida, even from the Washington, D.C. area. But we do have pockets, you know, that are hard to get to. It can take anywhere up to 2 hours to get to some long-term care facilities and even to other areas. So we are unique in that way. We probably only have about 1.8 million or so people who live in West Virginia, but so we're unique in the demographic sense. In that in mind, if someone can go to the next slide, please. Our governor did want us to develop what is called a Joint Interagency Task Force, which is in part led by our West Virginia National Guard. So it's a command structure. And it's similar to the concept, if anyone has read the book Team of Teams by General McChrystal. So It's a unified structure that is led by the National Guard. We do have other agencies involved, but the main point is that everyone is located in one unified building. So you have all of our stakeholders or people who've been participating at the start of the pandemic. So our hospital association, our long-term care associations, West Virginia Department of Education, the group that also runs all the federally qualified healthcare centers or community health centers. Each person who is a collaborative effort of that team is part of this joint interagency task force, or JIATF as we call it. This in part is what was able to propel us to at least be successful with the initial vaccine rollout, getting the shots into arms into these rural communities. Because as we're going to move forward, and Lisa Costello is going to talk about it more, communication is important as we get the vaccines into the future of the arms as we move forward, but communication is also in part at the base end of it, and communicating within the teams of these agencies to get information disseminated quickly, and also when to know to pivot, just as we had to do earlier this last week with the J&J. When the Johnson & Johnson news came out, I think before the CDC issued their health alert out, we already had our JIATF issued an alert out to all our local health departments. We had a statement by our communications team from the JIATF pushed out to every local partner that had this vaccine and said it had to be paused. And in addition to that, what are you going to do to all the locations who have this vaccine on hand? What vaccine are you going to send them? Because we don't want to stop the vaccines from being given to patients or being offered. What are you going to do to offer them and message to them the alternative solution? So this agency serves as a communication or command structure for that in the structure of West Virginia. But next slide, please. The long-term vaccination program was something that we are very proud of. West Virginia is also the first state in the country that was to test all the residents and staff members at the start of the COVID-19 pandemic. And that was also at the direction of our governor, who recognized that our long-term care residents were suffering very quickly from COVID-19 due to their age. The National Guard was also involved in that efforts going into the nursing homes, along with our health departments and other healthcare workers throughout the state. So we already knew that due to the rural locations, due to the demographics, due to the logistics, that when it came to the vaccine rollout, we would be able to do the vaccines as well. And that was one thing that we were very proud of. We did not enact the federal pharmacy program right away, mainly because we don't have a Walgreens and CVS at every corner. Our state is unique in that sense that most of the long-term care facilities sometimes have a mom and pop pharmacy who work with them. And that goes to that trust built up as well, as we talk about with messaging and communication. There's a long-term care that might have a mom and pop pharmacy that works with them forever. So that pharmacist can go into that long-term care, can talk to the resident, can talk to the staff member, and build up that trust with them about the vaccine. And you see that a lot that's happening, and that goes on in the community. So we were also able to finish our long-term care facilities first and second doses before the end of January of this year hit because of that. Due to our quick vaccine rollout, we have seen a huge decline in our SARS-CoV-2 cases in the first 13 to 14 weeks here in West Virginia. That is due in part because of this quick effort that was put out by everyone at our JIATF, which includes all the partners that I mentioned. We saw anywhere from 81% decline in nursing home staff and residents throughout. And there was at one point where I think we had 0 COVID cases in our nursing homes. But to the next slide, please. Because of partnerships throughout the state, we have 2 major universities really in our state: West Virginia University, which Lisa is a professor at, and then we have Marshall University. We have also began working on whole genomic sequencing for the variants. We initially were sending our samples to CDC as well as additional lab sources, but this is several months in the making. They were able to have the ability to test these variants at their lab. So that kind of partnership and that kind of collaboration is also something in West Virginia that people step up to the plate and want to be able to do things locally as well to kind of move things forward. Next slide, please. Governor Justice also initiated a program called Save Our Wisdom that goes along with the, epidemiology data we have that we were seeing our elderly population suffer from COVID-19 rather faster than any other age group. So before the recommendations for the vaccines to roll out, certain phases, we did have phases as well that were recommended by the immunization practices guidelines. However, we also pushed out the vaccines a lot faster before those recommendations, and we also did our vaccines in sequential order. We did not feel like the phases had to be done, at phase 1 complete, phase 1B complete, phase C complete. We felt that we need to get them in to people as quickly as possible, and that was also seemed to be effective because we have seen, as this slide indicates, we had data up until March 27th, a 93% decrease in deaths for our at least our 70 and above population. Of course, now things are changing across the United States, and we are seeing as well here in West Virginia where our hospitalizations are not so much as the 70-year-olds and above. We are seeing anywhere from our 40-year-olds to 60-year-old age groups coming into the hospital, just like anywhere else. We also pivoted rather quickly because of our schools. We did open up our schools. They are hybrid models, of course, as well as in-school models, but we opened up our vaccines several weeks earlier than most states to 16 and above due to Pfizer. So we have clinics made out for 16 and above as well as their family. We have family planning clinics so we can get the high school students vaccinated as quickly as possible because, of course, we also see high school outbreaks mainly in our sports teams. So we have moved rather quickly with those models, but next slide, please. This goes back to the messaging that Lisa has done with her team up at WVU. In December, they did a lot, and she'll probably talk about it in detail. They knew that the word mass vaccination clinic was not going to be voted well with people in West Virginia, so we came up with the word community vaccination clinics, and that is something that we know words do matter, so we don't use the word mass clinics here. We found out that people don't seem to associate well with that, so we use community words a lot, family words, and we were very cognizant of the word choices that we were, especially in rural West Virginia. The initial, driving force of getting vaccines, especially with Pfizer and the cold storage and the rural community. I mean, this was December where the weather was bad in West Virginia with snow. We had the typical wheel and spoke model where you had hubs of the vaccine and then we disseminated it as needed to the local health departments. But the important, I think, main takeaway really from West Virginia and its success in the rural demographics is that we did the team of teams model. We had the GIADF model here in West Virginia. We put a lot of people who care about West Virginia under one roof. They represented each team of their sector, the Department of Education, the Hospital Association, Long-Term Care Association. So you could easily walk and talk to someone. They would go back to their team. They were ready to pivot when something didn't go wrong. Because communication, as we know, is not only important to message out the vaccine properly with proper information, but communication within a team is also important to be transparent, to get the job done and be effective and efficient. And it's also important to note that it wasn't just for the vaccine. This team was working together at the start of the pandemic as well, and we can continue to work there. So that GIADF is still standing. There are still people who sit there every day. They probably get there before, 7:30, way before we ever do at least. So they sit there all day. And I think, communication is key moving forward for the COVID-19 pandemic. But the last slide is just my contact information, but if there's any questions later, thank you.
Thank you so much for sharing that. I'm not sure. Thank you so much for sharing that really insightful and informative sort of sense. I was particularly interested in that you were talking about the word choices and not using mass vaccination clinic, but community vaccination clinic. So knowing what your neighbors and partners would resonate with them was so important. We're going to pivot now and hear from Dr. Lisa Costello, who's, as mentioned, the Assistant Professor of Pediatrics at West Virginia University School of Medicine. So Dr. Costello.
Well, thank you so much, Dr. Smith, and to Dr. Amjad, and I appreciate everyone joining us today. I'm really bringing remarks on behalf of a very dynamic team that I'm grateful to be part of. Elaine Darling, who works with the Center for Rural Health Development, one of our key partners in regards to our messaging work here in West Virginia, and Dr. Julia Daisy Frostino, who's the director of the Public Interest Communication Research Lab at West Virginia University. As Dr. Amjad mentioned, we've worked very closely with. It's the first of its kind lab in the country that really looks at using social science for social good, and we've used them here and worked with them closely in West Virginia to help have data-driven communication strategies, along with Major Holly Nelson in the National Guard and Dr. Dan Totske, another member of our PIC lab. If you go ahead and advance to the next slide. So as Dr. Amjad mentioned, in West Virginia, we know that we often rank among the lowest U.S. health rankings. In fact, the Kaiser Family Foundation back in April 2020 rated us as the highest share of adults to have severe illness for COVID-19 illness. So we knew very early on that we needed to have a robust vaccination plan, including communications, to reach our population because we were at highest risk. You can go to the next slide. I'm actually coming to you from the Joint Interagency Task Force here in Charleston, West Virginia at our National Guard headquarters. And as Dr. Amjad mentioned, within that structure is our Joint Information Center. And really, the theme has been, and many of you who are in our virtual audience would probably agree, partnerships at the local level is really important to have coordinated communication. We have strived from the beginning to have clear, consistent, scientifically sound information that we can provide to West Virginians so they can make informed decisions for themselves and their families. And to do that, we need to understand the audiences, and we wanted to develop evidence-based messages to relay that information. You can go to the next slide. So what did we do here in West Virginia? We really wanted to understand the risk health beliefs, perceptions, attitudes, and behaviors. I'm a pediatrician by training, so we knew, just like in 2019, the World Health Organization deemed vaccine hesitancy as one of the top 10 global health threats. So we knew we needed to have robust communication effort. So we started well back in August. As soon as we started planning our vaccine efforts, we knew that communication had to be a clear part of that effort. And so we've used mixed method social science, using our really banking upon the expertise of risk crisis health communicators, along with strategic communicators, and then medical experts. And we've done this through quantitative inquiry, through surveys, population surveys, where we've done message testing experiments, as well as qualitative inquiries with focus groups, in-depth interviews, intercept interviews, along with direct observations. We continue to be flexible, and we know that we have to adapt our collection across all the phases, and then we use behavior change theory and resources from the CDC and others to ensure that our messages are data-driven and they meet the perceptions and the intentions, and we understand the beliefs of the West Virginians we're trying to reach. You can go to the next slide. And we do this through partnerships. So as Dr. Amjad mentioned, we have a joint interagency task force, and we also have many other subgroups, including a robust communication work group that has a variety of partners, from our Advisory Commission on African American Disparities, AARP, the Center for Rural Health Development, business, faith-based community, local health, primary care, the Hospital Association, and many others working together. We also have a robust medical advisory board that we run all of our information through to ensure that we are providing that clear, consistent, and scientifically sound information. That then subsequently gets coordinated through local-based, West Virginia-based public relation firm, Digital Relativity, that helps create some of the images that I will share with you later. And through all of this, we use data to translate those insights into tailored and targeted messaging, along with strategies and tactics, from information that we share when our pandemic leadership is communicating with the public, down to the local health officer. We strive to have clear, consistent, scientifically sound information being relayed. You can go ahead to the next slide. So what does this give us? It really gives us a unique social and cultural understanding of the beliefs and lived experiences. So that helps us co-create messages that resonate with our audience's self-interest. It's delivered through the channels they prefer, presented by the messengers they find credible and trustworthy, and we always strive to advance health equity. And in all of our messaging, we want to make sure that we're using culturally responsive language and that we're also verbally and visually inclusive in the images that we share. We know that people trust those within their own circles, and our information, as Brian said at the very beginning, continues to show that health professional and experts within those community at that local level are trusted sources of information. You can go to the next slide. So what have we really done in West Virginia? We have seen throughout from our initial analysis that started back in November before we put any shot in any arm in West Virginia, and we continue to study this and adapt through wave 2 to today and moving forward, that we really had to enhance confidence in vaccine development process. So we have to emphasize safety and effectiveness. We have seen time and time again that is the greatest predictor of vaccination was safety and effectiveness. So that's really what has been the basis for many of our messaging platforms. We also need to showcase motivating benefits. So we want to motivate, this is protection to self, family, the community, to live longer. So as we move to transition to talking about teens, some of our messaging has been vaccination is the safest way to prom. Vaccination is the safest way to graduation. So we've been trying to showcase those motivating benefits of an individual when they choose to be vaccinated or choose for their teen to be vaccinated. What will be some of those motivating benefits? We also have to message to remove barriers or perceived barriers. So cost has been a consistent theme that we have seen to come up as a potential barrier. We know that the vaccine is free, but we have to develop messages that relay that to the public, because this continues to be a perceived barrier of individuals would not seek vaccination because they thought that there was a cost. And through all of this, we need to underscore hope, optimism, trust, and confidence, especially from our relatable, local, trusted experts and opinion leaders, which in our data, consistent with the Beaumont Foundation, has been those local public health leaders, the local physician, the local health professional, pharmacist, nurse practitioner. And as Dr. Amjad mentioned, words matter. So I've been seeing in the chat, how did you know about mass? Well, when you look at mass vaccination, if you did this right now, we can do an exercise. Mass blank, fill in the blank, mass blank. When you ask that question to most people, they will fill in the blank with words that have a negative connotation. Mass shootings, mass genocide, mass incarceration. So we saw early on in our data that individuals said they would not go to a mass vaccination site. It also goes against what we've been preaching for the past year, right? Avoid mass gatherings. So we instead use the term community vaccination clinics, and we've been able to see consistently that individuals would be more likely to attend a community vaccination clinic other than a mass vaccination site. So we avoid using that term in West Virginia, and as you can see, we also then put that into our images. You can go to the next slide. So what about for particular populations? So when we're looking at messaging considerations for Black and African American West Virginians, we have to acknowledge the questions that they have and exude cautions rooted in historical realities of a long-standing system of systemic medical racism, and we have to be mindful of that. We also want to be sensitive to the perceived threats to freedom and choice. We talk a lot about in West Virginia that this is a choice. We hope individuals choose to be vaccinated. We also have to realize that they have a myriad of pressures, that they feel pressures that they need to be vaccinated and get those pressures from others. But we see consistently through our Black and African American West Virginians, as well as conservative West Virginians, that there's a great deal of trust in the faith-based community as well as family. And again, going back to that trust in local people who look like me and can relay those shared lived experiences. You go to the next slide, we'll talk about what have we learned from Spanish-speaking West Virginians. In West Virginia, we know that Spanish-speaking individuals, they use mainstream media. They're on Facebook. They just don't trust Facebook. And so when we're delivering messages, we have to be cognizant of who we're relaying information from. So in Spanish-speaking individuals, they do trust the CDC and top medical experts, and they trust science. Again, we see the faith-based community coming through here. And then particularly with our Spanish-speaking populations, they tend to trust pharmacists as the member of the healthcare professional team that they trust more. So ensuring that we're identifying messengers to relay messages in the way that our individuals want to receive them from the individuals they want to receive them. And they really want fact-based information from fluent Spanish-speaking community members and documents that are Spanish-speaking, which we've been able to adapt. Next slide. So we've implemented this in a variety of ways. I would direct everyone to our vaccinate.wv.gov site. We have a robust toolkit that we develop and that is run through our medical advisory board, again, using data-driven communication strategies to craft those messages. We also have a social press kit that we are able to update information. So when there was a pause in J&J, we were able to immediately go there, identify any graphics or messages that we have, and we were able to either take them down or adjust them depending upon what new information was changing. We also have other tailored resources to different populations, whether it was long-term care facilities or Department of Corrections, and we continue to have ongoing needs assessments so that we can identify what type of messages need created, who do they need to be delivered by, and what channels do we want to disseminate those messages through. So if you go to the next slide, we'll kind of go through this very quickly. I just want to share with you some of the examples that we've used of data-driven communication in West Virginia. The next slide is the core basis. This is our messaging platform. So we have seen the greatest predictors, again, of vaccination was safety and effectiveness coming from trusted sources. So this is this has been our messaging platform, safe, effective, trusted when it comes to COVID-19 vaccines. Next slide. You can see here that vaccination is the safest path to community immunity. We answer questions or we have facts that we share with individuals. This goes along with our whole theme, which is community immunity West Virginia. Again, going back to what we saw that tested well with our public of this community approach. If you go to the next slide, you can see that this goes to that community immunity begins with me, and that it's an individual choice, and that we're working this together, that it's me as part of the community that it begins with. Next slide. You can see we have other questions that I mentioned that we see that come through consistently in our quantitative and qualitative work, so that we can make sure that we're pushing out information to address the questions that we're hearing from West Virginians. If you go to the next slide, this is where we've talked about community vaccination clinic. We created an entire toolkit for our community vaccination clinic partners that has resources that they can share, whether it's through news media, social media, print media, that we're able to have that community vaccination clinic theme running through. Next slide. We also, as I mentioned before, translate many of our materials into Spanish so that we have the Spanish-speaking materials available on items that our Spanish-speaking individuals want to know the most about. If you go to the next slide, what we've seen consistently come up is about cost in our Spanish-speaking community, and that's what this graphic speaks to. If you go to the next slide, as a pediatrician, I thought it was very important to have stickers. So I have the stickers here, right here. I've pushed from it from the very beginning. But here you can see that we adapted the CDC material. I got my COVID-19 vaccine. We adapted that to have a West Virginia theme, and our hashtag West Virginia Strong has been part of our pandemic response since the beginning. If you go to the next slide, it all comes back to our COVID-19 vaccine priorities, which is what Dr. Amjad started her remarks with. No matter what the messages change throughout, our vaccine priorities have remained the same, and this has been emphasized by our governor. We'll protect the most vulnerable, reduce deaths, reduce hospitalizations, and maintain critical services and acute care. So if you go to the next slide, again, for us in West Virginia, it's been about partnerships, trust, and relationships, and it's been, as Dr. Amjad mentioned, the West Virginia way of working together, using data-driven communication strategies to ensure that we're understanding the intentions and beliefs, and that we're able to help West Virginians make an informed decisions for themselves and their families through clear, consistent, and scientifically sound information. If you go to the next slide, I think that's my contact information, and really appreciate the opportunity to share with you our story here in West Virginia.
Wow, Dr. Costello, thank you for that whirlwind tour. Thank you both, Dr. Amjad and Dr. Costello. I mean, it's so clear why West Virginia has had so much success, and thank you for taking us kind of behind the curtain to see how you all prepared for and created that. We're going to shift. We have just a few minutes left for questions and answers, and I know that there's already been a number in the chat, so we're going to try to get to at least 3 or 4 or more of them we can in the next few minutes. The first question we have is from Anirudh Rual from Ohio University, who asks, what specific strategies would you recommend if the goal is to overcome resistance, and specifically within the Appalachian population? And I would just tag on to that a question that I saw come through the chats is, how were you able to encourage or sort of get success with the long-term care staff. I think a lot of people were saying that they had a fair amount of staff refusal to be vaccinated. So two questions, sort of particular pockets, so Appalachian population and then long-term care facility staff.
Dr. Amjad, do you want me to take a stab at it and then I can, I'll transition to you. I think it goes back to our data-driven strategies. Our West Virginia Healthcare Association is part of our Joint Information Center. So we've had them at the table when it comes to long-term care, bringing individuals to the table so that we can have tailored and targeted outreach. We've had our medical advisory board meet with them. We always use our information talking about choice, making sure we know that also one of the that comes across all ages, ethnicities, occupations. One of the perceptions or fears, the single most common, is unknown long-term side effects. So we make sure that we address that through our different venues, whether we're talking to a specific long-term care population or the Department of Corrections or what have you. And I think to answer the first part of that question, as we work to build vaccine confidence, really listening with empathy, making sure that we're hearing what the concerns are and then providing trusted, credible information, not repeating the myth, as tempting as it can be, not bringing more, attention to the misinformation, but making sure that we're addressing the underlying question, but working to build that vaccine confidence through the local trusted partners.
Thank you, Dr. Costello. Dr. Amjad, is there anything you would add?
Hey.
Why don't we can pivot to the next question. Looks like maybe Dr. Amjad is getting.
No, no, I don't have anything to add. Thank you.
Great. Well, we do have a couple of questions from the chat, many questions from the chat. And I believe we have Michael Meet. Michael, do you want to ask your question? If you're not able to unmute, I will go ahead and ask it. He shares, West Virginia has been a shining star for early vaccine distribution, particularly in rural areas. Have you started to, quote, hit the wall that we have experienced in rural Tennessee and other rural places?
I can answer that. I wouldn't say that we've hit a wall. We do have some hesitancy in some areas, but we are still finding a lot of people who want the vaccine. Some people maybe have not been able to reach out, so we have seen numbers drop. But a lot of people are getting into rural areas such as homebound areas that we've tried to address, and we've also gotten into a lot of businesses. So we're doing some business models where we'll have mobile clinics go in and have some family members bring in their families who work there and then bring in those sites. So we haven't hit that wall yet, but it definitely has slowed down of the vaccine rollout.
Yeah, and the only thing I would add is that, it takes time to build these relationships and understand our audiences. And it really takes time in understanding what individuals' intentions to be vaccinated, their perceived barriers, fears that they have, to help overcome and really reach that movable middle that Brian talked about.
Great. So our next question is from Ilya Hopkins from the Mayo Clinic, and she asks, can you talk about the research that shows the difference between guilt versus shame as a motivator for those who are hesitant or resistant?
Sure, I can take a stab at this, and this is where I think really for us in West Virginia, having a crisis communicator and a health risk communicator and a strategic communicator as part of our team, we all work together. I think fear is not a good strategy that, we think it would potentially work, but it consistently shows time and time again that, fear is not the best motivator. And so I think it again goes back to listening to the people. We want to know what the perceptions, the intentions, the beliefs of West Virginians are, and then how can we address those through data-driven communication. And so learning about what are those perceived barriers, how can we then overcome that with messaging, and then what are other motivating factors that we can showcase that we know that is what an individual, needs to hear, and will help them make that choice to be vaccinated. So that's, I think that we have tried to shy away from that in West Virginia, just based upon the past literature, that those are not really the strategies that are best to understand or to move people to choose to be vaccinated.
Perfect. And you raised this earlier as one of the biggest concerns. Heather Murphy asks, how do you address the long-term effects of the vaccine that is novel?
Dr. Andrade, I can start again, and then if you want to chime in. I think certainly, that's what we've continued. I think we've been transparent, and we have to say what we know, and that this is an ongoing, as I thought Brian articulated well, that we will continue to monitor the safety and effectiveness, and being able to make sure that we have updated documents. We're about to release version 7 of our toolkit, so we provided a toolkit to West Virginians before the CDC launched theirs. I think that, we certainly use and appreciate all the resources from CDC, FDA, HHS just launched their We Got This campaign, and certainly direct individuals to that resource, to the Beaumont Foundation. So I think that we address that, from at this point, that we don't see long-term, side effects that usually, if they would occur, that, they would be within 2 weeks or, shortly after the vaccine, and that these vaccines have been studied through rigorous clinical trials, and that safety measures have not been skipped. And that's what we've really tried to take to address that. But as we've done our ongoing adaptive qualitative response, we try to bring to light the questions that we hear more frequently, and try to address them through the data that we have available, and the scientific evidence that is available at this point. But we do emphasize that this is an ongoing process, and that there's ongoing monitoring of safety, and that's why those different monitoring project or programs are in place.
Perfect, thank you. Dr. Smith, I think that will be our last question, just to make sure we cover off on a couple of last updates, if you want to wrap us up here.
Yes, well, thank you so much. I mean, you clearly got a sense of just how eager people are to learn from you, and I think it's quite appropriate that, one of the participants referred to you all as the shining stars. So that's terrific, and I saw that you put your information in the chat, and I suspect people will be reaching out to you. So thank you both for the amazing work that you're doing, and for joining us today, and for all that you are doing for public health generally, but especially for what you're doing for your neighbors in West Virginia.
Well, thank you, Dr. Amjad, Dr. Costello, and Dr. Smith for taking the time to share these insights about the amazing work that's being done in West Virginia. And thank you all for joining with us today, and for all you are doing for public health. Now, just hold for one more minute, because we're going to tell you about the theme for next month's webinar. But before doing that, we want to ask you one additional question, which we'd like you to fill out online. That relates to the fact that the Public Health Communication Collaborative wants to be useful to you. And so we want you to take just a moment to answer the question in the WebEx platform about what resources would be most useful for you in the coming weeks and months. Then we can devote our attention to addressing those. So just take a moment, please, to do that. While you're doing it, I will relay that our May webinar will be held on May 13th at 1 p.m. Eastern Standard Time. And the theme in May is going to be on an issue that is increasingly coming up, and that is summer travel or vacation travel, and how do we craft COVID-19 safety messages that will be useful and informative and accurate as people begin to plan for summer vacation. I also just want to remind you that for more resources for communicating about COVID-19, including the details of the polling that Brian mentioned, the tape from today, and the slides that you've seen in the presentation, please visit the Public Health Communication Collaborative website, and that website is publichealthcollaborative.org. That's one word, publichealthcollaborative.org. And you can see the past webinars, all the materials there, and we'll take the information that you're giving us in this poll. If there's anything we can do to support COVID-19 public health communications, please contact us also at info@publichealthcollaborative.org. That's info@publichealthcollaborative.org. Later today, you will receive a short survey that we ask you to complete to provide feedback on today's webinar, and that again will help us to tailor our offerings so that they're most useful to you. And again, a recording of this webinar will be available on our website later this week. So with that, again, let me thank our terrific panel and look forward to seeing you at next month's webinar. Take care.